The first case asks us to identify a diagnostic tool that would be useful in determining a deficiency in either beta oxidation or the urea cycle. A blood glucose test would not be helpful, as the products of the urea cycle are urea, waste product dispensed in urine, fumarate, a reactant in the citric acid cycle, and various phosphorylated compounds in free phosphate groups, while the products of beta oxidation are acetyl-CoA, a reactant in the citric acid cycle, and FADH2 and NADH, both used in the electron transport chain. A blood glucose level would not be helpful in identifying a disability in either the urea cycle or beta oxidation. Serum fatty acid panels are useful in determining the total levels of fatty acids in the blood. These tests are useful to identify disorders in fatty acid metabolism. Deficiencies in the urea cycle would have little impact on fatty acid levels in the blood. Furthermore, abnormalities in plasma fatty acid levels could not only be due to beta oxidation deficiencies, but also deficiencies in the packaging or metabolism of lipoproteins. Urinary acid panels are useful tools in diagnosing disorders in the metabolism of amino acids, especially in the metabolism of purine nucleotides. As neither beta oxidation nor the urea cycle are directly involved in the metabolism of amino acids, this tool would not be useful in this context. That leaves us with plasma glutamine levels. This diagnostic tool is very useful in diagnosing urea cycle disorders, as plasma glutamine levels, along with ammonia levels, are common indicators of urea cycle disorders, especially in newborns. This is because glutamate combines with ammonia in the blood to be converted into glutamine by glutamine synthetase, where it is delivered back to the liver and deaminated back to glutamate by glutaminase, and the ammonia is able to re-enter the urea cycle. A disorder in the urea cycle will cause elevated ammonia and often elevated glutamine levels, or a disorder in beta oxidation will not. Now it becomes important to look at what urea cycle reactants and intermediates are abnormal, as this will help us identify which enzyme in the urea cycle is deficient. We see that ammonia levels are very high, which is common in most urea cycle disorders, and citrulline levels are low. This means that the deficient enzyme is most likely upstream from citrulline in our cycle. This means that we must consider what the effect of deficiencies in both carbamyl phosphate synthetase and ornithine transcarbamylase would be, as both will cause lower levels of citrulline. However, what becomes relevant here is the elevated levels of orotic acid. Orotic acid is an intermediate in the synthesis of pyrimidine nucleotides. Carbamyl phosphate, also produced in the urea cycle, combines with aspartate, where it is ultimately converted to orotic acid, which then receives a phosphate group from phosphoribosyl pyrophosphate to generate a pyrimidine nucleotide. This indicates that carbamyl phosphate is currently being generated, so carbamyl phosphate synthetase must be functioning properly. That leaves us with ornithine transcarbamylase. With a deficiency in this enzyme, ammonia levels will be elevated, as is still common in most urea cycle disorders, and orotic acid will still be produced, as carbamyl phosphate synthetase will still be functioning properly, and citrulline levels will be low, as ornithine and carbamyl phosphate will be unable to be converted to citrulline. For the third case, we must consider what would be causing gout with a presentation of low levels of urinary uric acid and high levels of plasma urate. We can rule out overproduction of purines and decreased salvage of purines as the cause, as these would both lead to an increased production of uric acid, which is filtered and excreted through the kidneys in urine. While these causes would both explain the increased levels of plasma urate, they do not account for the low levels of urinary uric acid, which we would expect to see, as these would be elevated as uric acid is filtered and excreted by the kidneys in urine. Causes of overproduction of gout include PRPP synthetase overactivity, or HPRT deficiency. Therefore, we can expect the decreased excretion of urinary acid to be the primary cause for this case patient's symptoms. A decreased excretion in the urine would be cause for uric acid levels to build up in the blood and deposited as urate crystals in peripheral tissues. These deposits will often land in the first metatarsophalangeal joint space of the great toes, which is consistent with the findings in our patient. So while underexpression of urinary uric acid is the primary cause of our patient's symptoms, There may be a combined secondary cause linked to the overproduction or decreased salvage of purines that we cannot rule out with the data provided. Causes of a combined mechanism of gout often include deficiencies in the glucose 6-phosphate dehydrogenase enzyme or the fructose 1-phosphate aldolase enzyme. To explain to the patient why this disgusting level of soda consumption is not beneficial to his condition, we must take a step back and look over fructose metabolism once again, as this will be the sugar he will be exposed to in the form of high fructose corn syrup found in many sodas. Dietary fructose will be converted by a series of enzymes to glucose 6-phosphate, which can either enter the glycogen synthesis pathway or the pentose phosphate pathway. Once in the pentose phosphate pathway, glucose 6-phosphate will be used to generate ribose 5-phosphate, which will be used in the synthesis of nucleotides, including these purines, which will continue to be metabolized to uric acid, worsening our patient's conditions and symptoms. An immediate discontinuation of the consumption of soda, as well as a carbohydrate diet, should be recommended to the patient.